Hello students, I welcome you all to Obstetrics and Gynecology with Mackler. So in this module, we're going to deal about the treatment of fibroid, which is also called as leiomyoma. So basically, I have divided this topic into various fractions so that this might be easier for you and you can watch very selectively whatever treatment options you want. So in this first module, we are going to discuss about the general brief synopsis of the treatment of fibroid, where we are going to deal what is the first line, second line, third line management in case of fibroid, and how the treatment is decided for a patient depending upon the risk factors being present in her. And we have also discussed the medical management, that is the first line of management, in detail in this module. So in the subsequent module, we'll be dealing the second line management followed by the third line management as well. Okay, so this part 1 module is all about the first line management of fibroid. Okay, so while discussing about the management of fibroid, the first line of management in a case of fibroid is always going to be medical management. So what is the major use of this medical management is that there are actually two uses. So as we all know, the major complaint of a patient with fibroid is heavy menstrual bleeding. It's going to be heavy menstrual bleeding. And along with that, she might also be experiencing some pressure symptoms, dysmenorrhea, and so on. So the first line management, that is the medical management, it is mainly concerned to decrease the amount of bleeding in that female and to relieve the pressure symptoms. So with what kind of drugs and what sort of actions you can achieve this? So in order to decrease the amount of bleeding in her, you have to give some hormonal or non-hormonal approaches treatment to her. So only then the amount of bleeding will be decreased in her. At the same time, you have to decrease the size of the fibroid. Only then the pressure symptoms will be relieved. So in order to decrease the heavy menstrual bleeding, you have to give her drugs that are the non-hormonal or hormonal drugs, and when pressure is concerned, you have to decrease the size of the fibroid. So both these hormonal and non-hormonal management in medical management of fibroid is mainly concerned to decrease the amount of bleeding in that female and to decrease the size of the fibroid. So by decreasing the amount of bleeding, she will be relieved from the heavy menstrual bleeding, and by decreasing the size of fibroid, she will be relieved from the pressure symptoms she is experiencing. Yes? Okay. So in this part 1 module, we are going to discuss all about this medical management. So now, the second line of management, which we are going to discuss in the next module. So the second line of management is uterine artery embolization. So as you all know, what do you mean by embolization? So you will do embolization in a blood vessel only when there is increased amount of bleeding in a female. So in cases where there is failure of medical management, failure of first line, or failure of the medical management, but despite giving the medical management to the female, the amount of bleeding per vaginum is not decreased. The patient is still experiencing heavy menstrual bleeding despite the medical management. So the medical management is unsuccessful. So in order to decrease the amount of bleeding in her, you are going to embolize the uterine artery. As we all know, uterine artery is the anterior division of internal iliac artery, which supplies the entire uterus. So if you are going to decrease the amount of bleeding, you have to embolize the uterine artery. So by embolizing the uterine artery, one thing is that you're going to decrease the amount of bleeding in that female, right? So this can be achieved with the procedure of uterine artery embolization. So uterine artery embolization is the second line of management. Is that clear? Yes. And the first aim is that you're going to decrease the amount of bleeding in that female, and at the same time, the blood supply to the fibroid is going to be decreased. The blood supply to the fibroid, which is situated in the pseudocapsule, the blood vessel supplying the fibroid is running in the pseudocapsule surrounding the fibroid, that is going to be decreased because we are going to embolize the main artery which is supplying the uterus, that is the uterine artery. So uterine artery embolization is majorly concerned with to decrease the amount of bleeding in that female, and at the same time, it decreases the blood supply to the fibroid, resulting in decrease in size of the fibroid as well. So the first line of management is all the medical management, either non-hormonal or hormonal, and the second line of management is uterine artery embolization. Clear? Yes. Now moving to the third line of management. So you have tried the first line of management, it has failed, and now you have tried the second line of management, that is uterine artery embolization, and that has also failed. Now you move to the third line of management. So in third line of management, we have two approaches. So I divided this third line into 3A and 3B. So 3A is majorly concerned with minimally invasive ultrasound procedures. So with the help of ultrasound, you're going to do some procedure. And those are the high intensity focused ultrasound and the magnetic resonance focused ultrasound. So what do you mean by focused? So basically you're going to focus the ultrasound waves towards the fibroid. So it is going to result in coagulative necrosis of the fibroid. So these ultrasound waves which are going to be directed against the fibroid, it is going to cause necrosis of the fibroid. So through this ultrasound procedures which are minimally invasive, you are going to cause coagulative necrosis of the fibroid. So the third line of management of 3A is minimally invasive ultrasound procedures such as the high intensity focused ultrasound and the magnetic resonance focused ultrasound. Is that clear? Yes. So this is going to cause necrosis of the fibroid. Yes? Okay. Now the 3B. So the third line of management, 3B consists of hysterectomy. So despite trying all the management, the medical management, followed by the uterine artery embolization, and followed by, you have also tried the minimally invasive ultrasound procedures, and that has also failed. So despite the failure of all these management, the final management is hysterectomy. Hysterectomy is removal of the uterus. So if we are going to remove the uterus, the fibroid which is going to be present in the uterus, be it either submucosal, intramural or subserous fibroid, is going to be removed with the uterus sample. So the last management is hysterectomy. So initially we saw about the medical management which consists of hormonal and non-hormonal, followed by the second line of management which was uterine artery embolization, followed by the third line of management which was divided into 3A and 3B. 3A was dealing with the minimally invasive ultrasound procedures such as the high intensity focused ultrasound and magnetic resonance focused ultrasound. And 3B is the final management, that is, you're going to remove the uterus from the patient. So despite trying all this management, it has failed. So the final management, you're going to remove the uterus in that patient depending upon her wish. And what is that wish, we'll be discussing in detail further. So again, there is a rare procedure which has been performed for fibroid, and that is the endometrial ablation, where you're going to cause destruction of the endometrium of the uterus. That is, the uterine cavity is going to be destructed. So this endometrial ablation can only be performed in a patient who is not desiring any future pregnancy. If a patient, let's say for example a 35-year-old female who hasn't conceived yet, she is having fibroid now, and she is telling you that I have to conceive in the future, I'm going to get married, and then after 1 year I'm going to get conceived, I want to have my baby. So in such female, you can't go with such endometrial ablative procedures, which are some invasive procedures. So endometrial ablation is rarely performed for case of fibroid, but then the only indication for which endometrial ablation is performed in a patient of fibroid is that if the patient is a known case of bleeding disorder. Why? Because is that if you're going to perform some procedures, some minimally invasive procedures, or let's say for example you're going to plan hysterectomy or something in a female, it is going to result in increased amount of bleeding per vaginum in that female. So since she is a known case of bleeding disorder, you can't anticipate heavy amount of bleeding in her. So in order to stop that, the best procedure would be endometrial ablation, that you're going to cause the destruction of the endometrium of the uterus. So when compared to that hysterectomy, where bleeding has been, amount of bleeding is going to be higher, which is anticipated, compared to that, this endometrial ablation is comparatively safer in patients with known case of bleeding disorders. Clear? Yes. So these were the management, first line, second line and third line management in a patient of fibroid. So now I have a different management for you, and that is all about myomectomy. What do you mean by myomectomy? So as you all know, I explained in the previous module, myoma means leiomyoma. What do you mean by leiomyoma? So leiomyoma, myoma means fibroid, Ectomy means removal. So basically you're going to remove the fibroid. So how can you remove the fibroid? So you can remove the fibroid only when it is present in the uterine cavity. And what fibroids are situated in the uterine cavity? The submucosal fibroid. Submucosal fibroid is situated entirely inside the uterine cavity. So what are the three types of fibroid which are situated in the uterine cavity according to the Figo classification? So those are the type 0, 1 and 2. So type 0 is when it is entirely inside the uterus. Type 1 is more than 50% is inside the uterine cavity and less than 50% is in the intramural part. And type 2 is more than 50% is in the intramural part and less than 50% is in the uterine cavity part. Is that clear? Yes. So we have discussed about all these type 0, type 1, type 2 in the first module of fibroid. If you haven't watched it, please watch that and then come back here. Okay. So for type 0 and type 1 fibroid, which are majorly situated inside the uterine cavity, for these hysteroscopic myomectomy can be done. That is, with the help of hysteroscope, which you're going to introduce per vaginally, you enter the uterus and you remove the fibroid, which is also called as the myoma, with the help of clamp called myoma clamp. So with the help of clamp, you're going to just remove the fibroid from the uterine cavity. So you clamp the vessels and then you remove the fibroid from the uterine cavity. Is that clear? Yes. So this is the treatment of choice for type 0 and type 1 submucous fibroid. Because type 0 and type 1, the major part of the fibroid is lying in the uterine cavity. But when compared to type 2, type 2 is a type of fibroid where more than 50% of the fibroid is lying in the intramural part and only less than 50% is situated in the uterine cavity. So for those types of fibroid, you cannot achieve it by the hysteroscopy. So in that patients, you have to do either laparoscopic myomectomy or you can do abdominal myomectomy. Through the abdominal route, you can do this myomectomy, or with the help of laparoscopic ports, you can do this myomectomy. So for type 0 and type 1, hysteroscopic myomectomy can be done. For type 2, well, less than 50% of the fibroid is in the uterine cavity, abdominal or laparoscopic myomectomy has to be done. At the same time, any type of submucous fibroid which is more than 5 centimeter. So since it is going to be increase in size more than 5 centimeter, you have to do abdominal or laparoscopic myomectomy approach. You cannot remove a fibroid which is more than 5 centimeter through hysteroscopy. So for that case, you have to remove it by abdominal or laparoscopic route. So we'll be discussing all about the myomectomy in a separate module, but as of now, as a general discussion, we have learned about what are the steps of management, the first line, second line and third line management, followed by this myomectomy. So myomectomy is basically a procedure which is done to preserve the uterus, because in myomectomy you're just removing the fibroid or the leiomyoma. You're not going to remove the uterus, you're just removing the fibroid. So it is going to preserve the uterus. So in any patient who wants to decide future pregnancy, let's say for example a patient, a 35-year-old female, she's telling that in the next year I'm going to plan a pregnancy and I want to conceive and have a baby. So in such females, you cannot perform any invasive procedures. So in such females, you have to do some procedures which can preserve the uterus, and that is myomectomy. Is that clear? Yes. In such females, you cannot perform any invasive procedures like hysterectomy, or let's say uterine artery embolization cannot be done in a patient who is going to decide future pregnancy. At the same time, it cannot be done in a patient who is deciding future pregnancy. Hysterectomy cannot be done because uterus is very important. So in certain cases, depending upon the prerequisites and the wish of the patient, you cannot perform certain procedure. So as a group, these are the treatment which are done till date for fibroid. Depending upon the patient and her wish and the prerequisites and the indications and contraindications prevailing in her, the treatment will be picked up. Is that clear? Yes. So finally, we are moving to the main part of this module, that is the medical management. Yes, so basically the prerequisite is that whether the childbearing is complete or the childbearing is not complete. So depending upon the patient's wish only, you can further decide upon the treatment. Is that clear? Yes, you cannot perform hysterectomy in a patient whose childbearing is not complete. At the same time, you cannot perform uterine artery embolization in a patient whose childbearing is not complete. So, the decision of treatment is basically decided upon the prerequisites prevailing in that patient. Clear? Okay, so now just forget all those things. Now we are moving inside the medical management. So now we are going to discuss it according to a case. So case 1 says that the main complaint when the patient is coming is heavy menstrual bleeding. So if the main complaint is heavy menstrual bleeding, the treatment has to be to decrease the bleeding. Decrease the bleeding. So the treatment, the drug which you are going to select, the drug should have a potency to decrease the bleeding more than its capacity to decrease the size of the fibroid, because here the major complaint is only heavy menstrual bleeding and not pressure symptoms. If it is only heavy menstrual bleeding, the major drug which you are going to give should have a potency to decrease the amount of bleeding in that female. So what are the drugs? So now you can just classify it into non-hormonal and hormonal. So what are the non-hormonal drugs, you know? Yes, those are the tranexamic acid. Tranexamic acid will decrease the amount of bleeding in the patient, because tranexamic acid are what sort of drugs? They are the antifibrinolytics. So they are going to improve the blood clotting in that patient and decrease the amount of bleeding in the patients. So those are the non-hormonal management. And what are the hormonal management, you know? So the main hormonal management, the aim is to decrease the amount of bleeding. So the drug which I'm going to give is to decrease the amount of bleeding in that patient. So what can you achieve? You can either give oral combined pills, estrogen plus progesterone, or you can give progesterone. As we all know, estrogen is going to cause hyperproliferation of the uterine endometrium, and progesterone is going to support the uterine endometrium. So unless and until progesterone withdrawal doesn't happen, the patient is never going to bleed. So in order to stop bleeding in that patient, you give estrogen. So estrogen is going to prime the endometrium, followed by progesterone. So the main function of progesterone is to support the uterine endometrium, and it is going to prevent the bleeding in that patient. So either give estrogen plus progesterone as oral combined pills, or you can give only the progesterone. As we all know, fibroid or leiomyoma is mainly estrogen dependent tumor, but also it is dependent upon the progesterone. So fibroid is a estrogen plus progesterone dependent benign tumor of the uterus. Okay, so oral combined pills consist of estrogen plus progesterone. Now progesterone consists of what? So progesterone can either be given orally, or it can be given by intrauterine contraceptive device. So what is the intrauterine contraceptive device? Yes, it is the Mirena. Intrauterine contraceptive device Mirena contains about 52 milligram of progesterone, that is levonorgestrel, which releases about 20 microgram of progesterone per day. We have discussed this about in the management of abnormal uterine bleeding. We have discussed about the IUCD Mirena. So intrauterine contraceptive device is basically a device which is put inside the uterus of a female. So this device has 52 milligram of levonorgestrel, that is the progesterone. So every day this device is going to release about 20 microgram of progesterone per day. So the progesterone is going to be released every day from the device inside the uterus, and the major function of progesterone is to support the uterine endometrium, and it will prevent the amount of bleeding in that patient. So it can either be given orally, or it can be given by intrauterine contraceptive device Mirena. So currently this Mirena is much preferred than the oral progesterone. Is that clear? Okay. So we consider in medical management we had non-hormonal and hormonal. So non-hormonal was tranexamic acid, and when hormonal management was concerned, the aim is to achieve decreased amount of bleeding per vaginum. So in order to decrease the bleeding, the drug which I took was OCPs and progesterone. But now let's say for an instance that the main complaint the patient is having is heavy menstrual bleeding plus pressure symptoms. So pressure symptoms is also the major complaint of the patient. So now my aim is to decrease the amount of bleeding per vaginum and to decrease the size of the fibroid. So only when you decrease the size of the fibroid, the pressure symptoms which are exerted by this fibroid near the surrounding structures will be relieved. So for that reason, you have to decrease the size of the fibroid in order to achieve decrease the pressure symptoms experienced by the female. So what are those drugs? As we all know, the major rule here is that fibroid is an estrogen plus progesterone dependent tumor. But since we tell it is estrogen plus progesterone dependent tumor, but then it is mainly estrogen and then followed by progesterone dependent tumor. So in order to decrease the size of the fibroid, you have to give a drug which will decrease the amount of estrogen and progesterone in the body. So if the amount of estrogen and progesterone is going to decrease in the body, then the fibroid will lack estrogen and progesterone and it will eventually decrease in size instead of growing in size, right? So give drugs which are going to decrease the amount of estrogen and progesterone in the body of the female. So what are the drugs which decrease the amount of estrogen in the body? Those are called as anti-estrogenic drugs. Anti-estrogenic drugs. So what are the anti-estrogenic drugs, you know? So gonadotropin releasing hormone. So we all know that GnRH should act on the anterior pituitary in order to release the FSH and the LH. So then this FSH and LH will act upon the ovary. So this is the main sequence which we saw about when we are discussing about the menstrual cycle. At the same time, if you are going to give this GnRH drugs, so GnRH agonist or basically GnRH, gonadotropin releasing hormones are GnRH agonist. So if you're going to give this GnRH agonist in a continuous manner, what is going to happen? And what is going to happen if you give it in a pulsatile manner? If you give the GnRH agonist in a pulsatile manner, it is going to cause increase in amount of release of FSH and LH from the anterior pituitary. Subsequently, FSH and LH will act upon the ovary and it will release the estrogen and progesterone from the ovary. But if you give the GnRH agonist in a continuous manner, it will never act on the anterior pituitary and it will never release the FSH and LH from the anterior pituitary, and this FSH and LH cannot act on the ovary to release the estrogen and progesterone. So in order to decrease the estrogen and progesterone in the female's body, the major step is GnRH. So now what we are going to do is we are going to give GnRH agonist in a continuous manner. So GnRH agonist, if given in a continuous manner, it acts like antagonist. It acts like antagonist. GnRH agonist, if given in a continuous manner, it acts like an GnRH antagonist. But if GnRH agonist is given in a pulsatile manner, it has a positive feedback. It acts on the anterior pituitary and releases the FSH and LH. FSH and LH will act upon the ovary and releases the estrogen and progesterone. Since you are going to give in a continuous manner, it is going to have a negative feedback on the anterior pituitary and it will never release LH and FSH from the anterior pituitary. And since LH and FSH is not released from the anterior pituitary, it can never act on the ovary to release the estrogen and progesterone. Is that clear? Yes. Now what is the drug GnRH agonist? You know, it is the leuprolide. Leuprolide. For the examination purpose, you need to learn the terms as well, okay? Yes. At the same time, you can give GnRH antagonist. Antagonist or inhibitory drugs. GnRH agonist or excitatory drugs. But agonist, if given in a continuous manner, it acts like an inhibitory drug. So the GnRH antagonist we know is elagolix. Elagolix. Good. The other anti-estrogenic drug which we know is letrozole and danazole. But danazole is not much preferred. Why? Because is that The major side effect of danazol is hirsutism. The major side effect of danazol is hirsutism, where the amount of excessive facial hair around the chin, right? The female is going to have excessive amount of facial hair over the beard area or the chin area. She's going to experience excessive facial hair development. So the major side effect of danazol is hirsutism. So for that reason, danazol is not much preferred. The much preferred options are GnRH agonist in continuous fashion and GnRH antagonist, right? Okay, so these are the anti-estrogenic drugs. So when discussing about the anti-estrogenic drugs, we have GnRH agonist in a continuous fashion, antagonist, letrozole and danazol. Now let's discuss about the anti-progesterogenic drugs. What are the anti-progesterogenic drugs, you know? So those are the selective progesterone receptor modulator, selective progesterone receptor modulator. So what do you mean by selective progesterone receptor modulator? At certain sites, the progesterone is going to have an agonistic effect. At the certain sites in the body, the progesterone is going to have antagonistic effect. So selectively it is going to have agonistic and selectively it is going to have antagonistic effect in the body. So the major anti-progesterone drugs are the selective progesterone receptor modulator, that is the ulipristal, followed by we also have mifepristone, which is a progesterone antagonist. As we all know, mifepristone is the drug which has been given to a female who want to induce abortion. So in medical termination of pregnancy, you are going to give tablet mifepristone 200 microgram orally to the female. Why? Because is that we all know that progesterone is going to support the pregnancy. Once the amount of progesterone is going to lack, the support to the uterine endometrium is going to be lost as well. So for that reason, you are going to give mifepristone in medical termination of pregnancy. So similarly here, the progesterone antagonistic drug is mifepristone. So anti-estrogenic drugs are GnRH agonist, leuprolide antagonist, elagolix, letrozole, danazol. Anti-progesteronic drugs are the selective progesterone receptor modulator, that is ulipristal, followed by the mifepristone. Now I'm going to discuss about certain important points about this GnRH agonist and antagonist. So what are those? So the major two important points which you need to remember here is that GnRH agonist, if you are going to give in a continuous fashion, it is going to have an initial hike followed by dip in the levels of LH and FSH. Is that clear? As I told you, GnRH agonist usually, if given a pulsatile manner, it is going to act on the anterior pituitary and releases FSH and LH in a pulsatile manner. But if you are going to give it in a continuous manner, initially there can be a hike. Initially, there can be a hike in the levels of FSH and LH released from the anterior pituitary, but then later, the levels of FSH and LH which is released from the anterior pituitary is going to attain a dip. So the final result is a dip, but initially there is a hike. But then, when you give GnRH antagonist, since antagonist, the main effect of antagonist is an inhibitory action, there is going to be no hike. Initially itself, the main action initially itself is a dip in the levels of FSH and LH which is released from the anterior pituitary. So is that clear? So what drug which you will prefer between these two? I am going to prefer GnRH antagonist because the major effect of antagonist is an inhibitory action. But the major effect of GnRH agonist is not an inhibitory action, but only if you are going to give it in a continuous manner, it is going to have an inhibitory function. So preferably between these two drugs, I'm going to select GnRH antagonist because the main function is an inhibitory function, right? So initially itself it is going to cause a dip. There is going to be no hike when compared to GnRH agonist, which is given in a continuous fashion. Is that clear? Yes. And the major effect is that this GnRH agonist can be given orally. But this GnRH agonist, which is given in a continuous fashion, it cannot be given orally. It is not orally administered. So preferably between these two choices, since this GnRH antagonist can be given orally, at the same time, initially itself, it is going to cause a dip in the levels of FSH and LH, which is going to be released from the anterior pituitary. Initially itself, there is going to be a great dip. So for that reason, I'm going to select GnRH antagonist compared to GnRH agonist, which has to be given in a continuous fashion. Clear? Yes. So if I'm going to ask you the major drug to decrease the amount of bleeding in a patient. So the main complaint is heavy menstrual bleeding. You give estrogen plus progesterone oral combined pills, or you give progesterone as a pills or as IUCD Mirena, intrauterine contraceptive device Mirena. But if the major complaint is going to be pressure symptom along with heavy menstrual bleeding, in order to decrease the size of the fibroid, you have to give anti-estrogenic and anti-progesterone drugs. So among the anti-estrogenic and anti-progesterone drugs, which are the most effective drugs and which are the least effective drugs? So if the main complaint is to decrease the size of fibroid in order to relieve from the pressure symptoms experienced by the female, among the anti-estrogenic and anti-progesterone drugs, you have to select the GnRH antagonist, which is the elagolix, is much preferred. But in case if it is going to be a failure, then you can go with the GnRH agonist, which is not orally active and it has to be given in a continuous fashion, right? You're going to give GnRH agonist in a continuous fashion. But then even after administering GnRH agonist in a continuous fashion, there is no decrease in amount of bleeding and the size of the fibroid has not decreased. So now, since this is also going to fail, now I have to move to the next line of management. What is the next line of management which we discussed? So the second line of management was uterine artery embolization. So the second line of management, uterine artery embolization, will be discussed in the subsequent next module. I don't want you to saturate much. So whatever we discussed today is already a very big and volatile topic. But then I hope that I made it very simple for you. In case if you have any queries, please write to us in a Mackler handle and I will reach out to you as early as possible. And then please keep studying. So please keep revising whatever we studied today in this module, so that it will be easy for you when you watch the next module on the treatment of fibroid. Is that clear? Okay. So let's meet in the next subsequent module.